wanted to thank you guys for taking time out of your busy schedule to be here with us tonight. For those I haven't met, I'm Paul Chahal. I've been practicing with Atrophic oral surgery since the beginning of last year. I'm also pleased to be with you tonight and to be able to introduce our guest speaker, Dr. Chh.Sambhajinagar. Dr. Mahajan practices in India. He obtained his dental degree from the Government Dental College in Mumbai and has received additional training in Europe and the United States. He has practiced clinical dentistry for 40 years, including 17 years of implant dentistry. He started the Smile Care Foundation for Education, Clinical Research, and Service, and he's presently in a group practice with his son, who's an orthodontist, his daughter-in-law, who's an endodontist, and most importantly, with his wife, Dr. Rekha. Also, as a University of Michigan alumni myself, I'd be remiss to not mention that two of his children are also graduates of the University of Michigan. Dr. Mahajan readily shares his experience with many and mentors many dentists who want to excel in clinical work. Tonight he'll be speaking on immediate loading in the atrophic maxilla and mandible without grafting or sinus augmentation. Without further ado, please join me in welcoming Dr. Mahajan.
Good evening, everybody. It's really great pleasure for me to be in front of you and share some experience with implants. Right in the beginning, let me thank Dr. Gary Wadhwa and his team and Dr. Uttam Gurme, who happens to be my classmate way back in 1971 to 75 at Government Dental College, Mumbai. It's because of their encouragement I got the opportunity to share things with you. Going straight to the subject, you will always find that, oh, such a long headline stuff. But I think it encompasses many things, and it also encompasses the way we used to think, about implants. We were taught for many years, and almost all of us who have been doing implants for the last few years, we were taught that implants should be parallel to each other, straight, almost perpendicular to the bone, and then it has to have whatever crown, prosthesis, and if by chance an implant goes angulated by mistake or thing, we used to lose our sleep. Oh my God, what's going to happen? There's going to be bone loss, there's going to be trauma, there's going to be fracture, and so decades went like that till people have started thinking about putting angulated intention. So the whole idea of this bridge, Jerusalem Bridge, is this whole bridge is supported by an angle. Government Dental College, that's the place which I always love to show right in the beginning, because this school, this dental school gave me everything in my life. Gave good basic education, we had beautiful, very nice teachers, we had good many friends, like Dr. Kamra is here, and Uttam is of course there, and quite a few girlfriends also. One of them did dare to marry with me. She is with me for the last 40 years. I acknowledge her presence here. She is right here. And also my son, who graduated and post-graduated in orthodontics in GDC, daughter-in-law graduated and postgraduated in endodontics in GDC. So GDC has given me everything in my life. They say that people think of two things mainly. One is sex and another is money. But usually they don't want to talk about it. But of course, as a dentist, as a practitioner, we have to talk about money. And Uttam said, oh, don't talk about sex much. I mean, I would otherwise love to speak. But we will definitely talk about some part of costings of implant treatments, modalities that we can offer to the patient the best possible way. RRR, residual resorbed ridge, is inevitable consequence after the extraction. It is a post-extraction consequence and it cannot be avoided. The moment we extract the tooth in next few months and that progression goes on, the bone gets resorbed, the sinus increases, and it becomes almost difficult to put implants. And many cases, when they report to us, are after resorption. Well, if at all, and most of us will do the extractions, people lose their teeth because of their neglect, and sometimes we also not taking enough care to preserve their teeth. There was a time, nowadays it doesn't happen that way, but we give dentures, partial dentures, complete dentures, and what does happen? That means the person has got amputation done and he is on crutches. He's trying to walk with the crutches. And with the complete dentures, we keep on telling them, oh, it will get adjusted. Don't worry. You use this powder, you use this ointment, or use this paper, stick it, it will, everybody uses it. And we know that it is very difficult to do dentures on resorbed ridges. And over the period of time, ridges do get resorbed. Basic instinct starts with the oral cavity. And I don't know with the removable denture how people manage. See, with the removable denture, what happens? This was one of the interview, I think it was
सुनिए हम सब एक फन जा रहे थे बाहर क्योंकि एक हमारे
so with the removable denture and this is the situation, and when it happens it is very extremely embarrassing, I am sure. So these only removable dentures are capable of doing this. Dentally handicapped. I don't know really what happens in US, but in India, all handicapped people have special privileges, special discounts, special passes, special these things. But nobody considers dentally handicapped person as a handicapped person. I don't know, they never get any special discounts, they never get any special discount. But a person who has lost the teeth is dentally handicapped. The way suppose somebody has lost the arm or a leg or an eye, and then they are given extra mileage. But dentally handicapped, I don't know. And we do give removable dentures, and the removable dentures are ultimately gum strippers. It strips the gums. And most of the partial dentures are acrylic partial dentures, at least there. We do give cast partials, but ultimately partial dentures sit on the bone. And the natural tooth which is in the bone, everything changes. Lucky are we, sometimes when you get a patient with a large bone, good bone, then you can put implants and give full mouth prosthesis. But such patients are rare. What's happening? Demographic change world over. From reviving the last libido to learning new art forms. 60s never looked this petty before. 60 and above class. they have money, they are built to enjoy life. The concept of retirement is almost become defunct. I am running 64 and I don't want to retire. People want to live good life. The average life expectancy in US 85, 90, 85, 90, yeah? And the ladies are going to live longer. So what quality of life they are going to lead after 60s? And when most of them have lost many teeth or most of the teeth or in previous days all the teeth. The anthem is, if you look good, you feel good. Everybody wants to look good. See the amount of money in India. You walk and every few shops there is a beauty parlor. Everybody wants to go there. There are gyms. Everybody wants to look good. And naturally important. What happens with usual OPG? Our problem starts with the maxillary sinus and inferior angular nerve when it comes to implants. Post-extraction consequence. What is happening with the mandible? The normal mandible comes to this stage. The angle increases. The ventral nerve, the ventral foramina almost comes up. There is no enough space for dentures or anything to fit properly. It never fits. And then you saw what happens with the removable dentures. And yours is posterior maxilla. In posterior maxilla, because of the pneumatization, the whole thing expands. The space goes off, and there is absolutely no bone left. And this is where major problem starts after extractions. And people usually do not go for dentures immediately, or do not go for the implants immediately. They somehow try to keep on postponing the things, and then look at this. The inter-arch distance increases so much. How are we going to fill this place? This much space, if we have to restore, what are the solutions for this? How we are going to do that? As a professional dental surgeon or a dentist, what options we can give to the patient? Bridges. Ultimately, when we think about bridge, we are cutting a tooth. A natural enamel, once cut, is permanently cut. Unfortunately, it is irreversible loss of the tooth structure, natural structure. Though we say that, oh, we are giving beautiful bridges, we are actually spoiling the tooth. Not only that we are tooth cutters, but most of the bridges becomes a storehouse of bacteria. Tell me, all of us, how many times it becomes possible you have a cup of tea and immediately you take a floss, go beneath the bridge and clean it? Never. With 37.2 degrees centigrade temperature in the mouth, how much time does it take for bacteria to grow? So all the bridges invariably are storehouse of bacteria. Look at this. This is a book photograph, age only 41, and at the age of 49, look at her face. What's happened? The prominence of the cheese and the nose accentuates the appearance of age. They look so old, and nobody really wants to look old. Everybody wants to look young. And when such patient comes, what is our options? So many a times, for difficult situation, we have to have different type of options, like a Swiss knife, doing different ways. We'll see few cases how we will go ahead. Well, let me tell you right in the beginning here that if you have any questions in between, you can ask me, no problem. I don't get disturbed at all. I'm married for 40 years. So I'm used to listening. And I'm quietly I can listen. So you can ask anything, any time in between. No harm. Look at this first case. And what are our treatment options? Male, age only 45, wearing partial denture, cannot eat well, and wants fixed prosthesis. What are we going to do in such cases? Look at the sinuses. No bone. Is salt like this with partial denture and with a fixed prosthesis without sinus augmentation. We'll see how we will do that. The second case, what are the treatment options? Female, only 41 years old, never smiles, doesn't like smiling because see how it looks. So she's extremely conscious about her looks. Does not, though she needs total extraction, does not want to remain without teeth even for a day. She does not want removable dentures at all. Because in her words, when she got married, her mother-in-law had removable dentures. And she used to get nauseating even looking at her mother-in-law. Well, most of the time, at least in India, mother-in-law and daughter-in-law have conflicting opinions. So she does not want, she never wants to have a removable dentures. So what is the option here? Look at this. This is how she had come initially to us. And 2 years she was going from one dentist to another dentist to find solutions. Everybody had told her that she is going to need bilateral sinus augmentation, wait for 6 months, then implants, wait for 4 months, then prosthesis. She was not ready for that. So, same way, we will see this case in detail, how we could give her immediate prosthesis on the same day. This is pre and post. This is immediately after putting a prosthesis. You can see the skin, then those can be masked later on. Third case, what are the treatment options? Young again, 52 years, they are just mid-age, wears partial dentures. He prefers eating non-vegetarian food, and with the partial dentures, he cannot really eat hard food. And he has consulted many dentists. In his words, he has consulted 19 dentists before he came. Everybody again, same thing. No bone here, so sinus augmentation. 6 months, 8 months, all those who are doing sinus augmentations, 8 months minimum. Then implants. If there is not enough bone there, at least 4 millimeter. If it is not there, you cannot put implant that time. So again, after 4 months, again, that means almost a year. Patient wants immediate things. Pre and post. Look at the change that can happen. The case solved. We did intentionally keep these 2 teeth. We added little composite here so that we could get good vertical height. So his facial did not change. And only on upper 5, angulated. Here, whenever the tooth goes, if it goes, we will be able to put implant. And the best part is, we will be able to add in the same prosthetic frame. We don't have to repeat the whole frame. It is possible to just add on to that by doing wearing. And only teeth will need to be changed which are inaccurate. Age 70. Elderly patient. We had done his full mouth rehabilitation almost 14 years back. His bridges, both side bilateral bridges, they failed over the period of time. Naturally, no bone here, so I had told him that we will have to go for bilateral sinus augmentation and then do the thing. Patient had no money problem. He had a lot of faith in me, so he said, okay, we'll go for bilateral sinus augmentation. He goes home, and his young son, who is a techno-savvy, goes to YouTube, sees the videos, shows this to the father. Father says, "Nah, Baba, I don't want to do it." Gets scared of the blood, scared of the surgery. Patient refused to go for the surgery. Then later on, same thing was solved. We could give without sinus augmentation a fixed prosthesis by putting angulated implants distal to sinus, mesial to sinus. This implant was done some 12, 14 years back. I had done that implant. It's still working, so use the same implant here. Here we extracted one premolar, these are all gone, but still patient doesn't want to remove them, we are saving them and continue. So, implant supported prosthesis, many a times it does improve the face depth. Look at here, look at her vertical height. Patient looks old because you cannot give a denture with proper height because it becomes unstable and resolve this thing. You put few implants and ball and socket, it improves the facial looks because you can give a good vertical height to it. So the ball and socket is a good option, but ultimately it is a removable prosthesis. I am not sure whether one should give for upper. I have given few cases, but nowadays I advise not to give ball and socket denture for maxilla. It is not a viable thing. There are more complications. And the posterior part of the mandible does get resolved. So the fracture chances are increased. So this option is good for those patients who cannot afford fixed prosthesis. Nowadays, in few countries, at least 2 implants and a ball and socket is becoming almost a standard practice for lower complete dentures. Then, whenever there is a resorption, we need to do bone augmentations. That's the only way to create the bone. And autogenous bone is one of the most predictable. Now, autogenous bone, taking the bone from symphysis and putting it here, many times one has to do it, we do it. Patients are less ready, especially in an older age, when there is a huge bone augmentation is needed. For 1 to 2 teeth, many patients become ready and it works well. Oh, people have been taking bone from skull, but I don't know how patients agree. People take bone from the iliac crest. It is many a times it taken. It's a good sign for the autogenous bone. But again, there is a more morbidity. Patient is not ready. Patient says, this tooth is, yes, I'm going to get this thing, but I have to walk like this for 15 days. What to do about that? So there are other problems with it. Or bone splitting can be done. Direct sinus augmentation is a very predictable way to get bone height there. Again, patient's compliance, the complications associated with it are more. Nerve lateralization, I have never done, but people do it through implants, and oral surgeons, I am sure you must be doing it if patient is ready to pay for it.
We used to do it.
Used to do it.
Most oral surgeons don't have adaptation.
Yeah. Bone distraction is also a good process to increase the bones. Again, I am a general practitioner. And for a general practitioner, it is not that easy to do all such things. Then there are other options like narrow implant, mini implant, one piece, zygomatic, short, basal, these combinations. Everything has its own disadvantage. And when it comes to the treatment, it is better to see the back of the patient once than to see their faces over and over again. And it's better to see this beautiful back than the irritating patient coming every time. Oh, doc, this is the problem. Oh, doc, this is the problem. Next day again, concept night. So, ultimately, we have to, as a professional, we have to find out a solution where patient goes happy. And these days are not too far off, even in India. I need not talk about this part. this community of advocates, legal people, are always after. If they know, today, if I tell somebody that your tooth needs to be removed, and if I don't give the option of root canal treatment, the patient can sue me. Same way, if I don't give an option of implant and do a bridge cutting, patient has some sensitivity later on, and then patient knows that the bridge was, instead of bridge, the implant was a better option, the patient can sue. Same goes true with the full dentures. In India, there are cases in consumer court where the patient has sued the doctor that my lower denture does not fit. How can you take it? Every patient just asks for guarantee or warranty. When will it work? For every dollar they pay, they want value for it. So we should be able to give options. Now, what are the advantages of angular? So the angular is becoming a different way to think about implants. And more surface area. Once you get an angular implant, you have a more surface area for osteointegration. And the apex of the implant is in higher density than the posterior part. When the implant is getting inserted here, the density of the posterior maxilla is less, the density of the anterior maxilla is better, so the apex goes into a better density bone. Same case happens here, from posterior to here. Apex is in better density. So, which is directly proportional to the initial stability of the implant. It avoids anatomical landmarks like sinus, mandibular nerve, impacted teeth, bone plates. This is Dr. Benatu's slide. Look, beautifully he has avoided all the plates and put the full mouth prosthesis. Without angulated implant, this wouldn't be possible. Fractured implants, many a times, ultimately they do fracture after a few years, sometimes it can happen. And then to remove osteointegrated implant will always take away more bone. So they will land up with the problem, and in such cases, a good solution can be without removing that implant and putting angulated implant. Avoids bone grafting and nerve repositioning. Here, it will be almost impossible if this implant was not angulated like this. Because of giving angulated implant, the AP spread has increased. The cantilever has reduced. Now, this case, actually, I have done sinus augmentation on this side. I did unilateral that time and was waiting to do this side. Meanwhile, patient started saying, no, doctor, this is too much, I don't want to go for this. By that time, I did not know the concept of angulated implant. Meanwhile, when I learned about the angulated implant, I said, why not try it? And we did it. I avoided sinus augmentation. In the same patient, one side sinus augmentation done, because frankly speaking, I did not know that I could do the angulated implant and avoid that morbid procedure. Tuberosity area can be used. Many a times, the maxillary tuberosity is a good area for putting up implant. And it goes right up to the pterygoid process. The pterygoid plate gets a good cortical, bicortical support, and you can get a good prosthesis like this. So less number of implants, it is good biologically, it is economic, viable solution. Much more economic than putting 8 or 10 more implants and then giving ceramic prosthesis. And how do you give that support in ceramic prosthesis? Here, you can give a support like a complete denture, so the patient aesthetic needs are fulfilled. It is a comparatively very simple procedure. Cortical, because of the cortical support, the initial stability is good. So the immediate loading is possible. See now here, because of this cortical support, this patient was done immediate loading, same day. Morning you start, by evening everything is given. Here you will see that I have given two more extra implants because patient is a heavy smoker. Smoking is definitely reduces the prognosis. But here we had to take extra support. Patient wanted it immediately, and we came to this position from here. Look at this patient's oral hygiene. He is a professor in college. Look at his things. He doesn't want to go in the college without a team. So same day solution and condition improved. So to start extraction in the morning, put implants, and by evening give fixed prosthesis. We'll see how it is to be done, protocol. So whenever one thinks from axial implant to angulated implant, there are many questions which come. Like questions like, what about the primary stability? We are doing extraction and immediately putting implant. How do we get the immediate stability? Whether there will be more bone loss, whether there will be fracture of the component because of the angulation, the forces are going to come in a different way, or there is going to be a high stress concentration. So the questions are going to be more and more. And all these questions, whenever clinically we do and this question comes, science is the best way. So you go to the literature and see what people have studied, what people have done, and Francetti in 2010 and Crespi in 2012 papers are published. There is no significant difference in the bone loss in tilted and axial implant, and there is no significant difference between the maxilla and mandible. These papers are published. What to do about regarding fracture of the components? Mallow in 2011, prosthetic screw loosening happens, but it is very easily resolved with screw tightening and occlusal adjustments. Once the occlusal adjustment done, the screw loosening does not happen. Abutment loosening and excessive wear marks in the prosthesis due to parafunctions. If the patient has parafunctions, then there are problems. But no fracture of components. This is what Mallow says in 2011. My personal experience that there are more problems with prosthetics than actually implants. We'll see that. Higher stress concentration also, Pretmano has published in 2000, and there is, whenever there is a single implant, tilting is totally different. Should not be done as far as possible. But with multiple implants, rigid fixation, it is very much possible. Now, Dr. Paolo Mallow in 1993,
What strain gauge measurement?
what?
Your last slide shows strain gauge measurement. What is that?
Yeah. See, they duplicate the whole thing in the laboratory. The masticatory forces and all. They try to duplicate in the laboratory and try to do the repeated motions and try to get the values. Now in 93, Paulo at Lisbon, Portugal, invented this concept of all-on-4 angulated implant. Before that, I don't know whether somebody had thought about it. And in 98, Nobel Implants published the retrospective results, studies, and it really gained high popularity. Today, Nobel's all-on-4 concept is very highly popular. They promote it very well, but there is a big but into that. The process is limited to 10 to 12 teeth only. That means many times only up to premolars. If you want to go behind, especially in maxilla, you have to give cantilever. Maxilla cantilever distal extension causes biomechanical complication. See, the maxilla is very porous. It is not like mandible. And in maxilla, having cantilever is an invitation for complications. Funnily they say all on 4 but none on 3. And loss of any one implant reverts the entire procedure to the initial stage. Or it can be all on floor also. So in maxilla, all on 4 is really, unless you are ready to take a risk or ready to, and then there are many people who advocate all on 4, they say, oh, my patient can eat up to premolar. They are fine. Nobody is fine. The nature otherwise won't give molars. But if you put all on 6, then it totally avoids the cantilever and there is no biomechanical complication. So just adding 2 implants in posterior region solves the problem. Not that every time it is possible, because this case I started, look at the sinus, it has become such a huge one, resorption, because the patient was wearing removable complete denture for long many years. We could give upper 4, lower is beautifully, you can see the span. If I put a straight implant here, the cantilever will be much more. The chances of complication are more. Here we had to do the bilateral sinus augmentation and additional implant later on. So the whole concept almost goes like this. Old bridge with straight implants, straight support, and the latest new bridge with an angular support. This is where my first case of angular implant find. I had started this case, the patient came that with the complaint that she got bridges done few years back, but she cannot eat properly. Now see the bridges. The cantilever here, root pieces here. Cantilever here, and hardly any tooth there. How will patient eat? So patient was ready for complete full mouth implant prosthesis. In one sitting, we did finish lower and upper. Bilateral sinus augmentation I had planned at a later stage. Patient had some marriage in her house, so she said we will do it later on. So we gave lower fixed and upper removable complete denture. Patient was okay, adjusting with that. And meanwhile, I learned about this angulated concept, and I told her, gave an option that why not try this. We put implant here and avoid sinus augmentation. Wow! Patient was happy. Oh, no more 2 surgeries. Avoided. And it will be over within 4 months. That means no 1 year waiting. Patient was happy. It becomes more economic. It becomes less morbid. Look at this area. This is the area where the angular implant goes posterior to sinus. Axial sections of the pterygopalatine area, and this was my first experience with angulated implant. Intentionally angulated in the posterior view. Good support, and there are reports available, multiple reports, 14 multi-centric reports, 14 centers, 1,283 patients, 5,267 implants, 5 to 10 years follow-up. Mallow in 2006, again in 2007, Transit in 2008, Comas in 2009. All these people have published papers. They have done all the study. So it's not just the fancy of doing angulated implant. It is well-known, proved fact. Evidence based. There is a lot of evidence. You go and see all these papers, they are available. Letmano, he did tinted versus non-tinted study. It's available. Finite element analysis was done. But it is with titanium implants, abutment and screw and being fused as a one solid part. This is very important. 50 Newton force was used. And Japanese he has published the paper in 2007, long back. So, in splinted implant model, stress at the most coronal bone to implant contact is identical irrespective of the angle of the tilt. Because many a time we used to feel that if you give an angulated implant and the force goes like this, there will be bone loss. But it has been proved conclusively that from 0 degree to 45 degree, whatever may be the angle, the force, the coronal, most coronal bone implant contact is identical. There is no difference. So this is our first case. Going ahead, lower fix was given. We will find clear, sufficient space beneath for patient to clean with the brush, normal brush or a interdental brush. Very easily can be cleaned. Look at the angle. In maxilla, invariably you have to put implants buccopalatine, because this is where the whole resorption takes place. And when this resorption takes place, this is how the implant go. And so this is a conventional impression post. There we thought about going to TMA, trans-mucosal attachment, which changes the angle. See, this is thinking at a later stage. Initially we had not planned this. Initially we had planned conventional. But later on, once I came to know about the angulated implants, and we could manage to put two posterior angulated implant, now we want to change this prosthesis. So this is little later on thinking. But see how it works. Conventional impression post, and after putting trans-mucosal attachment, TMA. Now TMA change the angle by 30 degrees directly. If this is the angle of the implant, the TMA will do it at 30, change to 30 degrees. So the TMAs are available 30 degrees, 17 degrees and 0 degrees. So depending upon the need. Afterwards, pattern raising trial, pre-casting trial, complete castable framework is made. Then we tried, from the cast to mount, we had to transfer it every time. This was the first case and the last time we did it this way. Otherwise now, once you plan this, you put TMA, fix it, it remains there for long life. You don't have to do it again. But here we have to. So as per lab suggestion, we change the angles. Ultimately, this TMA gain. This is a very interesting thing. Now, if your implants are going and angulated, how do you register the impression? Because if it is angulated, registering impression is not going to be easy. The tray will not even go inside. There is a very simple way of taking the impression. This is a no tray impression. There is no tray used at all. But still you can get a perfect impression, very simple, very economical, by joining splinting way and then take the impression. We will see the slides later on. These are few laboratory steps for casting. This casting ready. And laboratory steps. And so this is the shift in the thinking. Because of this, total shift. You can find some flaw here which was corrected afterwards. And this was the final prosthesis. Enough space for the patient to clean beneath. For maxillary, there is enough space given from the palatal side. So patient can put the brush. From pre to post. Happy patient, problem solved. Before and after. Same patient, I mean another patient where all on 6 for up and all on 4 for lower. Now, mandible all on 4 works for mandible because mandible is a strong bone. It can bear that force. Maxilla cannot bear. If we just think, what does nature do? For lower premolar, nature gives 1 root. For upper premolar, 2 roots. For lower molar, 2 roots. For upper molar, 3 roots. So that means nature itself gives more support for maxillary because it needs more support because the bone is soft. While lower, that is why for lower, all on 4 works. For upper, all on 6 works. What about the patients who do not want to remain without teeth even for a single day? They are so conscious that I want to, yes, I need to remove my teeth. I know, but I don't want to remain without teeth. And that removable denture, oh no, that's not my job. I cannot. I simply cannot. Then what is the solution? Yes, teeth are the first to be seen on the face. Beautifully done. Lipstick salad. So full mouth immediate loading protocol. There is a particular protocol that needs to be followed when you load it immediately on the same day. It has to be screw retained rigid metallic bridge. Botulinum toxin to the muscle of mastication 2 weeks pre-operative, injected, unless the opposing jaw is edentulous. Why? Because patient is not supposed to chew. And even if you tell patient, oh, you are supposed to have a diet which 1-year child has. And the patient goes home, you are given upper lower fix. And the patient says, yeah, I can eat this. I'll eat softer. Yes. Next day, something else. Okay, I'll try that. We don't have any control. So, injecting botulinum toxin in masseter and temporalis actually paralyzes the muscle for about 8 to 10 weeks. And it gains the strength. Nothing happens. It is the best solution for immediate loading. No chance of taking any risk. It has to have a bicortical support. Primary stability of the implant is important. Meticulous occlusal adjustments is necessary. And soft diet for 6 weeks. Soft diet means a diet which 1-year child has. Because if you load it immediately and you give occlusal forces like that, there are more chances of failure. Because the more initial stability is good, and after a week or 2, actually the stability reduces. So you have to be very careful that time. Again, papers, again literature. You dig the literature and you will find that Capelli has done this paper in 2007 with 3 years follow-up. In maxilla, 97.59% success. In mandible, 100% success. And to them, prosthetics is 100% success. For us, we have some problem with the prosthetics that we will see, but can be very easily solved. So this was the first case, first case which we were discussing. Second case, what will be the solution for this? The patient came like this, needs to complete removal of all the teeth and putting up implant, does not want removable, then what to do? Then after 2 years, she came back again. Because we offered her to give immediate fixed restoration, immediate fixed prosthesis, she was ready. So, her scan, start in the morning, extract the teeth, As usual, immediate loading protocol is different. Immediate putting implant protocol is different. That you know, I need not discuss it there here. PRA. Does everybody, all of you use PRA in your clinic? If you are not using, please try and find out. It is very easy. It is free. It is just patient's blood. To making PRA doesn't need anything. Platelet-rich fibrinogen. You need just a centrifuge. That's it. So simple. And it gives wonderful results. It gives wonderful results in periodontics, even disinfection. You put PRF anywhere and the healing is better, far better. For most of the implant cases, nowadays we have started using PRF and somehow the results are good. It is free, no chemicals have to be added, nothing solves the problem. So the implants were instead done and we could do this. You can see it is like, this could have gone this way. But I could put 4 implants up and 4 implants go down and immediate impression, titanium sleeves. Sometimes there are some arrangements, many times I don't know, in the clinics you have to do some adjustments. We call it Indian jugaad. Something we have to do adjustments and satisfy. Somehow I couldn't find that rubber band, so we use sterile glove to separate the wood from the acrylic flowing. The cold cure acrylic is one of the best friend of the dentist. It really helps. So start in the morning, impression is taken, but we adjusted her previous denture. So the whole denture is adjusted from the lab like this, and then screw retake prosthesis given by data. Patient is happy. Patient could not afford both prosthesis. So only upper patient is quite happy. Because lower as such, it's okay. It's not seen much. This is the patient's aesthetic need, looks, and that is fulfilled. You see the angle of the implants. This is trans-mucosal attachments used. Impression, very simple technique of making the structure, strong structure here, very solid structure. You use just the putty. For final impression, you can use wash impression. But if you are putting immediate loading, immediately after the extraction and implant, then one should not use wash impression, because there is chances that it will flow in the wound. So there only putty is sufficient. It gives good. Our main intention is to transfer the position of the implant to the laboratory. We don't need very sharp impressions at all. Yes?
Go back a slide.
Yes.
What is the nature of the material that you have running between the injection ports?
This?
Yeah, what is that?
A wire. Simple aluminum wire or
Paper?
not paper clip. It is little thicker. They use it for fencing or something. Very simple wire. Just a little flexible. Very economic. Use with spirit or some. And because there is no, afterwards like taking normal. Very simple. And this is, I will show. This red stuff is pattern resin. You can also use self-cure composite instead of pattern resin. Slightly expensive. I mean, it is expensive as compared to pattern resin. And pattern resin, it is very easy to remove it later on. Very simple to use. So you unscrew it and the whole thing comes out and the impressions are ready. Send to the laboratory. Laboratory makes cast. Regular, routine, normal jaw relation. Record the jaw relation. Take trial. And patient is happy. You know, in India, they like to eat some crunchy stuff many a time. And after putting this, she said, after long many years, she could eat that missile, that crunchy little rubbery thing to eat. For many years, she could not. That was the satisfaction she had. Now, the pterygopalatine implant, there is a 1-minute video, you will see how it works. You have to take access properly. It is done under local anesthesia, no sedation, no IV. I don't call an oral surgeon. Not that I'm oral surgeon, not because, but I need to say it's not that difficult at all. Not like putting high. See, on the right side, there was small complication. The bone fractured. So I stopped. After 6 weeks, I did it there. But this side, we could put the same time. And then this is a TNA, trans-mucosal attachment is fixed. At the same time, that you can see, you can very well appreciate here the change in the direction. This is the direction of the implant, and this is going to be the prosthetic screw or the prosthesis. This is how the final thing came up. And the girl who never used to smile or refused to smile anytime, after giving this prosthesis, always smile. She can't stop smiling. She's so happy. She got dignity. She could eat properly. She's enjoying her life there. Look at this case. Comparatively young, beautiful lady in her 40s, comes like this, looks like this, lost many teeth. Start in the morning, put PMAs. In her case, we opted to keep few teeth just as a support to maintain the vertical height, so that she could use her old partial denture for next 3 months till we could go for the final prosthesis. And from here, on the same day, this was little long, I have just marked it here black, because this is acrylic. You can very easily adjust it in the mouth also. But from here to here, patient was very happy. Final prosthesis, this is a rigid metal framework, casting done. One can also go for CAD-CAM. It is possible to go for CAD-CAM, complete framework. The only thing is it is expensive. Casting is much cheaper. Yes?
What does some of the procedures in India cost?
What does this procedure, the whole procedure in India cost?
Yeah, like the last case that you
To
did,
me, this case, to me, including implants, including prosthesis, including laboratory, costs around $2,000. To me. So I have to charge maybe $6,000, $8,000. It's very cheap, very, very costly. For full mouth prosthesis, I am sure, how much are here? Now that you opened up the topic. $40,000. $40,000. That means with this procedure, you should be able to really satisfy the patient in 10,000, 15,000, 20,000. Patient will be too happy. Less morbid, simple, easy to do. No extra surgeries. It's from here, she's taken here. Now, here again, see, there were impacted molars. We didn't touch it. Leave it like that. Gave little extra implants here. There These teeth were used just to maintain her partial denture for next 3 months till she got the final prosthesis. Yes, please.
Do you worry that, like those with anterior, that they're gonna contaminate the implants and compromise them? Like,
These teeth,
yeah, if you keep those teeth, you said you clean them to maintain the vertical.
never seen contamination.
Oh, right. So
They
you're
see
worried
you do thorough takeover.
about-
Do thorough takeover naturally before starting the case. At that time, the patient is on antibiotics. That also not very high antibiotics. Not like sinus augmentation. Sinus augmentation infection causes no. Here actually nothing. You do a thorough periodics and there is no active infection. The teeth are bad, of course. And the moment you take impressions, everything is removed. But by that time, she had prosthesis on these front implants. This is prosthetic skills. So she had that temporary prosthesis. So her need not to remain without teeth even for a single day is fulfilled. Look at this. She's wearing a whatever prosthesis she had in the mouth, looks very gloomy. After her retirement, she said, I lost my confidence because my teeth were removed and whatever was given, she was not happy. She always used to say that my students always say that, ma'am, you have beautiful smile, and I lost that smile. I lost that confidence. I lost that dignity. This is what she used to say, and this is after the prosthesis. We'll see this case in short. Look at this. She was wearing a lower partial denture, upper bridge here. Some of the dentists have tried to do the best of the work, but her anterior maxilla was so much resolved that he couldn't do anything better than this. Complete palatal cover. Patient is never happy with it. Nobody really likes it. But we dentists say, oh, one has to lead the life like that. But once they come to know that it is not necessary and the other options are available, they will go for it. Look at the bridge which was given. And you just imagine that in our mouth, if there is anything small thing stuck up, we will take a floss, we will take a stick, try to remove it. It is so irritating. And when we give partial dentures and complete dentures, and we tell the patient, oh, you have to adjust it like this. Such a huge thing, patient keeps on adjusting in the mouth. They manage it somehow because we tell them that there is no other alternative. Actually, there is alternative. So, look at this, from complete palatal cover, this fixes, and everything is screw retained. You can easily take it out within 10 minutes if needed. I have seen few cases where people have given ridge lap prosthesis, which should never be given because ridge lap prosthesis will attract plaque, bacteria. If you give a good clearance here, tell the patient right in the beginning, you have a choice. Either you will have a clearance where you can clean, or you will not have a clearance where you will not fill the gap, but your mouth will stink. Go ask your partner and then tell me more. Nobody has said, give me ridge lap in all these years. Everybody wants clean, fresh mouth. So, things look quite beautiful, you know. Nice case, nice thing work. Does it really work every time? Quote of the day. Success comes from good judgment. Good judgment comes from experience. And experience comes from bad judgment. Judgments do go wrong. And once they go wrong, sometimes we have to face it. But one learns, and they are very easily avoided. When the complications comes, look at this. This is how patient went and came after about 6 or 8 months, I don't remember, came like this. teeth knocked off or plaque, not cleaning well. But this was because of my and my labs not really understanding the occlusal concepts. The anterior guidance, the lateral guidance, canine protected occlusion or group protected occlusion. Today we have a very renowned prosthodontist from Boston, teaches in the, and he will be able to maybe guide me later on about the occlusion part of it. But these are not very difficult. If that care is taken, this will not happen. This happened because of heavy occlusal load. The masticatory load is so heavy, and when we have a natural teeth, because of the proprioceptive receptors, patient understands that, okay, enough. With full mouth implant, patient never understands whether he is giving normal load or extra load. And patient gives load, keeps on giving load as much as possible. And that is why the fractures happen. Another case with fracture. See, the whole tooth has popped off from here. Because that occlusal adjustment is very important. But because these dentures are made of acrylic, it is easy. It is more forgiving than PFM, porcelain fused to metal, or so-called zirconias nowadays. Everybody wants to give zirconia crowns. I don't know how much forgiving they are. So all on four for angulated with TNA in atrophic mandible. See, we all know that maxilla is usually not much of the problem with removable dentures. People manage, it remains. But mandible, oh my God. And these elderly people with lower mandible, they are easy. See, most of the teeth, they are retired. In India, they in the morning, they will do some good temple, do this, do that. And they have ample time. Have breakfast and go and sit in the dentist's clinic, surgery. And worst thing, they will keep on complaining when they are sitting in the reception. Oh, why can't you complain once you come inside? But right in front of other patients, the dentures they are never satisfied. So the lower denture, how do you solve the problem? Look at this case, very interesting. Patient, almost more than 75, has Parkinsonism. He all the time he's shaky like this, cannot use dentures at all. Does not want to remove his upper teeth because he cannot use the lower dentures were done for him. The referring doctor was really attempting to do good dentures, but nothing was possible. Totally without reach. So there we gave him all on 4 in mandible, and you saw the pterygopalatine implant. Same way goes from distal to the mental foramen. It goes distomesially. Distomesially and apically. This is a DNA fitted trans-mucosal attachment. See, this is the angle of the implant and this is the angle position of the prosthetic screw. So this DNA brings prosthetic screw into favorable position where we can handle it. See, this is the angle change. And this is how you can take an immediate impression because it also converts hex into non-hex. All those who are taking prosthetic, because there are many people who do not do implants but do prosthetics. So that way full mouth prosthesis is so easy to do. Once you learn this concept of TMA and taking impression, simple. Everything lab does, very simple. And for us, lab charges very less. I think one day it will be possible to send the work anywhere in the world, get it done, and you are happy. the angulated implant code. This is how it goes. All on 4, an angulated TMA, lab procedures. It's like a normal acrylic denture. After once you do the casting of the, the lab does the casting of the framework, everything is like a normal denture. Very simple. Look at the size of the tongue. Over the period of time, after the removal of the teeth, even the tongue increases in the size. It becomes impossible for a denture to remain there. Look at the upper teeth, they are so bad, but patient did not want to remove, he was scared. And the dentist said that she will be able to do the post, core and save, and luckily it has worked well. Patient has started eating properly. Patient's family members are extremely happy that at his age he can eat everything. Prosthetics again, see the tissue surface of the prosthesis should always be convex and highly polished, so that it does not attract plaque but can clean easily. Patient was with Parkinsonism happy. You can do a good service to other humans. Another case. Look at his face. Always angry. Always looking like this. For 18 years, this patient eats with only upper denture, because lower denture he cannot put at all. So his daughter-in-law says, "Oh my God, lunchtime and dinner time is a problem for us." He keeps on grumbling all the time. He loves to eat, in India they call it papad. It's a crunchy thing. The people like to eat that. And he cannot eat that. And he gets irritated because of that. Because he doesn't have lower teeth at all. Upper he is managing somehow. Look at his x-rays. See, you find the mental foramen is almost come on the crest of the bone. So the moment he puts his denture there, it pains. He cannot eat it. So he is using only upper denture and lower mouth. He is 80, but his children want him to have a good life further. Once he came to know that something like this is possible, see the angulated implant, look at the ridge. Forget about the convexity of the ridge. At some places it has become a concave. Look at the scan results. 4 mm, 5 mm, hardly bone above the nerve. Casting. Sometimes there is huge casting, but this casting is very light. The metal is very light. It's possible. We have to give huge casting and then go for it. The lab person initially thought this jaw relation is wrong, because so much, the space was so big, we had to fill it. Casting done. How do you assess that clinically, whether the casting is fitting well? There are few tips about it. Alternate finger pressure, direct vision and tactile sensation, radiographs, one screw test, screw resistance test. Many things can be seen, and it can be very easily corrected. If at all casting is wrong, it can be very easily corrected. First of all, you have to have an accurate replica. Accurate impression has to be there. For that, splinting of the impression post is important, as you very rightly asked the question. Splint the impression posts and then take the impression. The chances of mistake will be reduced totally. Correction of casting error can be done very easily by sectioning and then welding again or soldering again, or both things can be bypassed, as you saw in certain cases where directly the prosthesis is bonded to the sleeves. They are ready-made sleeves, you get titanium sleeves, they can be fixed, and the whole prosthesis can be either bonded or for transitory this thing with the acrylic it can be fixed. See here the casting went wrong somewhere. So you do the sectioning there and there itself, again join it and again build. So it's not very difficult. Joint taken later on. AP spread is very important. How far you can extend the cantilever. In mandible, the mid of the anterior most implant to the posterior line of the posterior most implants, double the that can be cantilever. AP spread. Mid of the anterior most implant and the posterior most implant, the distal part of the posterior most implant, double that. In mandible, in maxilla, I don't give cantilevers because it is more risky, more problematic. Best thing is give posterior implant and avoid cantilever. Even in mandible, whenever possible, you can put an implant, even in small implant, mini implant, 6 mm, 5 mm, and give a support. It is better. But when it is not possible, you can always give a cantilever in mandible. This was the prosthesis. Final prosthesis. Upper, he was happy with the removable complete denture. So we kept removable complete denture because upper, even with angulated implant, it was not possible. It was that resolved. He is 80 years old. He is using dentures for so many years. His main problem was lower denture, so that he can eat properly. The Indian naan, chapati they call it, something like that, papad. He wants to eat that. And before and after. Look at his eyes. Look at the smile is seen in the eyes. He is happy. His children are happy. His granddaughter is very happy. And the daughter-in-law is very happy. And I am also happy. Yeah, they stay in joint family. I am happy because could give good service. They paid good money. Everything works well. So benefit. If I had told him any bone augmentation, I am sure he would have. Not possible. At the age of 80, it is very difficult to convince the patient. And patients are going to lead life after that. This was done, I think, 2 years back. Now comes the problem when you get a periodontally affected teeth. In US, do you have periodontitis? There is? People have periodontitis here also? I thought it is only problem of third world countries. Okay. Then what do? When people need anterior dangling teeth to be extracted, and I am sure everybody doesn't have huge insurance, and we need to give some solutions to them, and many a times one has to give a solution. So, can we put implants in periodontally infected tooth socket immediately after extraction? Madam, your problem, right? Your question, right? Yes, you asked. Very, very, very nice question. Very valid question. Can you put it periodontally infected? Can we load them on the same day? These questions do come. So whenever there are questions for any clinician, the best thing is Google it. Nowadays, any problem, just Google it or call your friend or internet, ask the questions. I was just talking with this smart gentleman, young doctor, that it is nowadays so easy to use a WhatsApp application, send pictures, take advice, share. Unfortunately, at least there, many a times professionals like us are not ready to share knowledge. I don't know what happens here. Here, I think everybody is very open. This doesn't speak. I mean, see, the best thing is to share the knowledge. Best thing is to spread the knowledge. And that's why maybe I am here today, and that's what I like about Dr. Vadva, because he is always ready to share. Can we load them? So, what are the Mallow again in 2007 has done the study and he has done in 184 patients, 433 implants, 5-year study, 1-year study, all types of restorations in tilted and all on 4. Mainly he does all on 4. This all on 6 concept is comparatively new. Comparatively. So, but the problem with this Mallow's paper was he excluded the criteria of bruxism, stressful professional situation, emotional instability, and unrealistic aesthetic demands. Now, at least in my practice, if my almost every patient has either bruxism or professional stress, all married people have professional stress, those who are working. All men have professional stress. Or family stress, all women, wives have professional family stress, at least in India. Because in India, all men, they'll come home, the lady will be ready with a cup of tea and everything, he will sit. There is a clear-cut distribution of work. All grocery, cleaning, bringing up children, their education, disciplining, everything is taken care by wives. And all very important work, like discussing what Obama should do, what Modi should do, whether we should have nuclear missile or not, that discussion is left to men. They'll sit with a cup of tea, previously, nowadays with a bottle of beer, and discuss. But that distribution of work is very good for us. But all patients ultimately have this stress, or emotional instability, or unrealistic demands. Every patient comes like this. So if we exclude this, then which are the patients? So we thought, forget about this exclusion, let's do the cases. Patient comes, periodontally extremely compromised, needs extraction, doesn't want to be without teeth at all, not even a single day. How do you do? Can we put implants? Can we load it? Look at an cast, chromatic bite. Yes, people do have something like this. X-ray. But the referring dentist did not want to do anything here, so he went for bridge here, extracted and bridge here. They were only interested in anterior. That's okay. Started in the morning. Again, please note the angle of, because that is changed with the TMA. This is the angle of the implant, and this is going to be the angle of the prosthetic screw. So the TMA will bring the prosthetic screw in favorable position, change hex into non-hex. Because of the non-hex, the impression of the even angulated becomes perfect. There is no question of the angle. Otherwise, two hex will never fit into each other properly. Using PRF in such cases, most of the periodically compromised teeth, the moment you extract the tooth, I prefer to flush the cavity with antibiotic solution like Augmentation, mixed with metronidazole, chlorhexidine, and then curate everything. Once you curate everything, patient is already under antibiotic, there is no infection. There is no periodontitis once there is no periodontia. Yeah. So it works like a healthy bone. So many a times you put this PRA, it works like a beautiful membrane. You put it like a collar around the implant and it just adapts itself. Put stitches and healing is much better. The PRA, once you centrifuge it, the upper portion is a liquidy yellowish. The middle portion is this. With a tweezer you take it out, cut the down red blood cell part, and this is the clot which is used. can be directly used as a clot or can be used as a membrane. Now there are companies who sell PRF machine and then PRF this machine to press and all, nothing needed. Plain, simple centrifuge machine works as that 1 lakh rupees or something PRF machine which the company sell. It works the same way. See this angulated implant to avoid sinus here. Titanium sleeves, the prosthesis is made immediately. Good morning to good afternoon. These periodically compromised cases can be done very easily, very nicely, and they work well. Same patient, very happy. After 3 months, 4 months, final impression. Then that time you take trial, then you want to give a PFN, whatever prosthesis of your patient's choice can be given. Now look at this case. This is going to be the last case. And female, 79 years, severe atrophic maxilla. Look at the maxilla where it has gone. Way inside, the upper mandibular teeth are like this. The lower teeth are reasonably good, firm. But only 3 teeth are okay, that we decided not to extract. All types of removable dentures were tried. All types. Cast partial, acrylic partial, then flexible dentures, everything, nothing. See, with such a huge negative distance between the mandibular teeth and the maxilla, where did they see? And this shrinking of the maxilla is not only in the anterior region, but it is also in the posterior region. The whole maxilla is shrunk like this. Where do you put implant? The anterior region, the bone has become very thin. Patient is almost 80. Full mouth, bone augmentation, the complete this thing, taking a bone from her hip area. Oh my God. I won't be happy. Patient was never happy. We were trying to find a solution for her. This was her. See, whatever she had, she broke this, everything was going wrong. But we decided to keep this endo and then crown to maintain the height. And see, this is how 4 angulated implants. And this is the 5th one which I did later on. Unfortunately, I couldn't find the X-ray my laptop here. But I did this 5th implant also here. And this complete prosthesis. Here there is no chance of putting it. Now all these implants, you will appreciate that they are bucco-palatal angle. Because of the severe resorption, they are bucco-palatal angle. Look at the positioning of the lower teeth. It is way class 3 everywhere. But with these 5 implants, impression again with TMA, with tray, no tray impression technique, prosthesis. Screw retained prosthesis, and in the anterior region we gave acrylic because that is for the aesthetic reason. And the end result is this: posteriorly ceramic teeth, anteriorly acrylic, and this is the end result. Friends, this is the case which I want to follow. This is the solution given to this patient where I am most happy. I am most happy as a dentist and as a son, because that's my mother. At the age of 80, she could be given this solution where she can eat. In India they call it chana phutana, nuts. She loves eating that. She eats it there. If this solution, simple solution, can be given to your mother and you can watch her every day eating properly, I think that is the biggest satisfaction as a professional and as a dentist. They always say there are people who make things happen, those who watch what happens, and those who wonder what happens. And I am sure that all of you are one of the upper crest who will make things happen for good of the society, for good as a professional. This is our team. I'll just take a minute to talk about the Smile Care Foundation. This is, see, I am 64, almost retired. I don't need to work really. Now, this through Smile Care Foundation, we conduct courses to teach very economic, because I feel that very expensive courses are sometimes deterrent for further education. Here we have a facility where a doctor can actually work on the patient, and those are the patients who are done as a charity patients. Because there are huge number everywhere in the world who cannot afford. So we try to help them in such a way that the doctor actually work on the patients. So the part of the expenses are covered and the patient gets the needed treatment. Only high quality, high-end treatments when patient, once I go back to India, I have a patient who is 18 years old and has not a single tooth in the mouth and had to do something, coming from middle income group. So such cases can be done under charity. Doctors there are coming, learning. The whole idea of coming here, because my daughter is here, I come. Friend like Uttam and Gary Vadhva, I talked with them. I said we like to share. The whole idea is to share, is to spread that these things are possible. Thank you very much. You have been really kind and very nice audience. Thank you. Pardon?
Bone graft, what do you use?
Bone grafting, which bone I will use? If it is freeze-dried, eradicated bone, I most of the time use from Tata Bone Bank. In India, there is a Tata Cancer Institute. They have it, and it's very economic. It costs me around $50 for such chunk of bone. And that is, otherwise, any other powders are available. This powders, granules. Indian are also available, or otherwise Rocky Mountain. Standard one is always considered Rocky Mountain, but economic solutions are available.